how it's grown last 8 years or so. Really largely owing to the people who have been running it, and how enabling it to grow, but also because this is such an important space, this interface between anthropology, sociology, uh, psychology, the mental health sphere, a space that is growing in importance and will continue to grow in importance in the coming years. So I see only excellent things for this network going forward into the future. So thanks to all the people who are keeping it going and developing it and growing it. Really, really well done. Amazing to see. Um, all right, so today, in my presentation, I aim to do three things. The first thing I'd like to do is a little bit of anthropology of home. This is anthropology of home, effectively. I'm going to give you a case study of some of the problems of the mental health sector in the UK more broadly. So I'm going to give you an outline of what some of those may be. Secondly, I'm going to give you an example of how we can recruit anthropological ideas, the anthropological imagination, to solve social problems in various domains. And in this respect, I'm going to be focusing on the mental health sector and a particular crisis that we are currently experiencing in the UK at the moment in that sector. So the power of anthropological ideas to help us solve problems. And the third thing I'm aiming to do here is give you an example of the kind of presentation I would deliver to people in the mental health sector, to psychologists, to mental health professionals, not necessarily anthropologists. So this isn't designed for anthropologists. A lot of the ideas that I'm going to discuss with you today, you will know very, very well. How do we communicate our ideas in an accessible and engaging way to the very people we would like to influence in other domains of inquiry? So this is an example of how at least I've attempted to do that. Okay, does that sound clear? All right. So, well, let me start by just defining the problem, which I tried to work out by way of writing this project. And it was really to do with the contradiction that bemused me, which is, if a social institution is failing, what happens? If a company, a private company is failing, if it's not doing well, if it's not profitable, what happens to that company? Well, that company, it either folds and goes under and disappears, or it dramatically reforms. It doesn't carry on doing the same thing. But this is precisely what I would argue is happening in the mental health sector in the UK. It is failing, and yet it is not reforming, and it's carrying on. And not only is it carrying on doing the same thing, it's expanding. Its influence and power is expanding, while at the same time as not doing very well at all. And just to substantiate the idea it's not doing well, I want to refer to something that the eminent British professor of clinical psychology once said. Professor Richard Bentle, your supervisor, once said, when reflecting on the state of clinical outcomes in the mental health sector in the UK. He said the following: "If as a child I had contracted leukemia, my chances of survival were around 20%. But if a child today contracts leukemia, their chances of survival are around 80%. That constitutes an improvement in outcomes of around 300% over the last 40 years. And this remarkable feat isn't just reserved for pediatric oncology, because we can see impressive rates of improvement in almost every other domain of medicine." I say in almost every other domain because sadly there is one exception: the area of psychiatry and mental health. When we look at this area, the area in which I, and I suspect many of you also work, not only have outcomes broadly flatlined over that same time period, but according to some measures, they have effectively got worse. So, for example, the efficacy of our psychotropic medications hasn't actually improved over the last 35 years or so, despite billions spent in research and marketing and promotion of these products. When we look at population level rates of mental health disability, these have trebled in the last 25 years, while we also see rates of prevalence of mental health problems continuing to grow inordinately, despite general levels of well-being in the community not necessarily getting worse, at least up until a few years ago to the pandemic. Also, when we look at people who are suffering from the severest forms of mental distress, the gap between their life expectancy and everyone else has actually widened by double in the last 25 years, from 10 to 20 years. And these dire statistics exist despite our having invested, in the UK at least, over £250 billion in mental health services and research since the 1980s. Okay, so there's been a lot of money going into this sector, but the outcomes have not got better. So what is going so sorely wrong? Well, to understand this, I want us to take a seemingly unconventional route. I want us to go back to Paris, 1844, to this Café Rougeon in Paris, to discuss to when two young men met to discuss a terrible epidemic that was then sweeping across Europe. One they believed that was rooted in the rising and rapacious industrialism of the age. For these men, industrialization was making people sick because it was so exploitative. The captains of industry were paying people on unlivable wages under terrible working conditions to inflate their profit margins. And these two men became convinced that these exploitative arrangements had become so normalized in the economy that people had lost touch with their essential human rights and needs, leaving them in a state of political apathy where they no longer believed they could fight for a better world. And in this demoralized state, all that remained for them were soothing illusions and anesthetics, sedatives to compensate them for the painful oppression they endured. Now, the two men in that Parisian Paris were, of course, Friedrich Engels and Karl Marx. And by the time of this, their very first meeting, Marx had already set about identifying what he considered to be one of the most powerful sedatives of the age, which was for him, of course, organized religion. Now, just to remind you, Marx argued that religion, by teaching people that their suffering in this life would be rewarded in the next life, was teaching people, and usually the most disadvantaged people, to accept and endure rather than to fight and reform the oppressive circumstances affecting them. As religion, in effect, sedated the distress that would otherwise galvanize political action, he famously referred to it as the opium of the people, an ideological sedative powerful enough to disable the human impulse for social reform. Now, while most of you, students of sociology and anthropology, will be familiar with this Marxist critique, we can't forget how radical it was at that time. In fact, what Marx's early writings on religion helped establish was effectively an entirely new and enduring style of analysis in the social sciences, one that would be deployed in subsequent decades by both thinkers on the left and the right, and one that focused on the following: how the main institutions of society, right, whether we're looking at law, education, media, healthcare, how these main institutions would always adapt themselves to what the economic paradigm of the day demanded of them, coming in effect to serve the economy's will. You know ideas about superstructure, the economic superstructure to which other social institutions adapted, etc., and so forth. But Marx also said, and this is perhaps not as well known, he said that This adaptation was particularly true of those social institutions like religion that directly explained and tried to manage human suffering. After all, once a sufficient number of people came to suffer under a given set of economic arrangements, those arrangements wouldn't survive for long. People would either challenge them through the democratic process, through organized opposition, or when such processes failed, through civil unrest. Consequently, those social institutions responsible for managing emotional distress were critically important to the aims of any economy. They had the power to diffuse politically dangerous emotions by sedating sufferers to the real social drivers of their distress and by distracting them from what should really be the true targets of their reform. Okay, now the reason I've taken this detour into the salons of 18th century Paris is because I believe that the ideas hatched back then can help us go some way in explaining the failure of our mental health sector in the UK to improve its outcomes since the 1980s, during the period of what has been dubbed, late capitalism or neoliberalism. In other words, what I want to explore is how, since the 1980s, our mental health sector in the UK, by struggling to thrive under this new set of neoliberal economic arrangements, has inadvertently adapted itself to serve the needs of these arrangements, but at the expense of generating the good clinical outcomes we all want and deserve. So how has this adaptation worked? What are the mechanisms that have enabled the mental health sector to become a kind of handmaiden to neoliberalism? And this is where anthropology comes in. So what I'm going to do in the following discussion is recruit long-tested, well-known anthropological ideas to make sense of how this adaptation has worked. Okay? And remember, this is a presentation, is a kind of an example of how I would communicate anthropological ideas to a non-anthropological audience. So the first mechanism that has enabled this adaptation of the sector to fit the needs of neoliberalism is, of course, one you'll all have heard of, overmedicalization, the overmedicalization of our emotional, behavioral, and mental lives. And these are some classic texts that look at the experiences of overmedicalization or medicalization processes in different contexts and trace the sociological implications. Now, since the 1980s, the control of the psychiatric profession, under the control of the psychiatric profession, the mental health sector has progressively renamed more and more of our natural or normal, albeit painful human experiences to the difficulties of living. It's renamed them as mental disorders, requiring some kind of mental health intervention. In other words, it's progressively medicalized them. And it's achieved this through manuals like the DSM, the book that lists all the mental disorders believed to exist. And in the case of the DSM, as many of you now know, we've seen a rapid expansion of the number of disorders from around 100 in the 70s to 360 or so today. In addition, these manuals have progressively lowered the bar for what constitutes having a mental disorder, in effect, making it far easier for any of us to be classed as mentally ill. So by expanding the definition of illness to encompass ever more domains of human experience, this sector has not only reconfigured how we respond to distress in healthcare settings, but how we respond to distress in the wider social world. And when I say we, I'm talking about the UK, but I don't think this is just specific to the UK. So whether we're looking at behavioral problems at school, underperformance at work, grief at a significant loss, the effects of unemployment, discrimination, abuse, trauma, poverty, social exclusion, etc., and so forth. These are some of the manifold painful human experiences now liable to psychiatric framing and psychotropic intervention. Now, of course, the over-medicalization of everyday life has been unwritten, and I spoke a little bit about this yesterday, and I'll say a little bit more about it today, underwritten and promoted by the very industry set to benefit most from it, which is, of course, the pharma industry, which has colluded with DSM's expansion, with the over-medicalization of everyday life at every turn. After all, once widespread suffering has been medicalized and pathologized, now large swathes of the population must now be treated. And the treatments our governments have generally preferred since the 1980s have been psychopharmaceutical. And so this brings me to another concept that will enable us to describe a mechanism that has enabled our sector to come to serve neoliberalism. And this is commodification, the process by which our mental health sector has transfigured suffering into a vibrant market opportunity. Now, it's almost common knowledge that most of the people who wrote the DSM had financial ties to the pharmaceutical industry. So this is a really interesting study by Lisa Cosgrove in PLOS Medicine, and she's looking at the financial conflicts of interests on the DSM-4 committees. And what she found was that on the committees that were responsible for working on the diagnoses for which drugs are the first-line treatment, all members of those committees had financial ties to the pharmaceutical industry. And when we look at, the task force that put together DSM-5, which is the most recent version, there were 27 members on that task force. 21 had financial ties to the industry, including the chair and the vice chair. So, the financial ties are legendary, and these have palpable effects on decision making, etc., and so forth. In fact, here's Robert Spitzer, who was chair of the most important edition of DSM, which is DSM-3, and this is what he said. The pharmaceuticals were delighted with the DSM, presumably because it created a vast and highly lucrative market for their products. Let me just give you an anecdotal example of how the pharma industry has promoted DSM and, in effect, the over-medicalization of everyday life. So in 2015, I was in New York City. And I was set the following day to deliver a presentation at Columbia University on the making of DSM. And the night before, I realized I'd like to look up the sales figures for DSM. Okay, so I went online and I started searching to see if I could find how well it was doing. And this was 6 months after its publication. This is DSM-5, 6 months after its publication. And I'm looking online and I stumbled upon something that truly shocked me, which was Amazon.com. On Amazon.com, the best-selling book in America was DSM-5. And just to give you a sense of scale here, Harry Potter, number 6, 50 Shades of Grey, which no doubt you've all read, number 9, right? Also, how much do you think it cost a copy, paperback copy of DSM-5? No, not quite, but $88 a copy. $88 for a paperback copy, and it is number 1. And it had been in the number 5, it had been in the top 5 for 6 months since its publication. All right. So a few days later, I'm interviewing wonderful medical anthropologist, Emily Martin. No doubt some of you have heard of her at NYU. We have our interview. Come to the end of the interview, and I say to Emily Martin, I've just seen this online. What do you make of it? And her response to me was, oh, James, you don't know. No, I don't know. Tell me what I don't know. And she said the following. And this is based on her experience working in the primary care sector in the New York State area and other. The bottom line is that the pharmaceutical industry has been buying the DSM in bulk and then distributing copies for free to clinicians up and down the country. That's why the figures are soaring. For her, it was obvious why the pharma industry would do this. Almost any kind of suffering is caught by the DSM. Disseminating it is just good business. It drives up diagnosis rates and with this prescriptions. So when I was at the APA, I was at the DSM archives. I checked with the archivist. We went to the publications department to try and verify all of this, and we asked them, "Where do you sell this?" And it turns out that the APA sells most of DSM in big bulk sales, right? Then we asked them, "Well, who are you selling these to in bulk?" And that's the point at which they slammed the door shut and they wouldn't tell us. But who else is going to be buying DSM in bulk? I mean, think about it. So we haven't got proper verification, but you get the point. So that's an example of how the pharma industry is pushing DSM. I want to give you another example. This relates specifically to the UK situation, and this concerns this document, PHQ-9. I mentioned it yesterday. One of the most powerful documents in the mental health sector in Britain. Why? This is the depression questionnaire that doctors, primary care physicians in the UK distribute to clients to determine, number one, whether or not they have depression, and if so, how severely, okay? They don't use it as much today, but this was certainly very dominant for 15 years. Now, one of the major criticisms of this document is that it sets the bar very, very low for what constitutes having the level of a kind of depression for which a drug should be prescribed. And by the way, if you look at the data, around 90% of patients who fill this in will get prescribed a medication, an antidepressant as a consequence. Now, what the tens of millions of people who've filled these in and got prescriptions as a consequence almost certainly didn't know was that this questionnaire was developed by, its distribution throughout the NHS was paid for by, and its copyright was owned by Pfizer Pharmaceuticals, which incidentally makes two of the most prescribed anti-anxiety and antidepressant drugs in the UK. So here you have a company setting the bar for what constitutes needing a drug, while at the same time as making, selling, and profiting from that drug. And that's been going on within NHS for a long, long time. So in other words, to come back to commodification, the spread of medicalisation has therefore opened the door to the unrestrained commodification of our distress, creating a vast psychiatric drug market now worth over, I think this is a conservative figure, $40 billion a year, which I mentioned in our panel yesterday. Now, the main benefactors of this market have, of course, as I mentioned yesterday, been the shareholders, some political allies, and those mental health organizations who've been in wide receipt of industry money in the form of consultancy fees, speakers' fees, sponsorship donations, research funding, other contributions, and honoraria, all being types of remuneration that research has shown again and again bias recipients in favor of these industry products. And the literature supporting this is huge. So while the commodification of human distress has proven profitable to sections of the psychiatric, corporate, and certain areas of the political community, successfully monetizing the management of human distress, the consumers themselves from whom all this profit is derived may well have some cause for complaint, given the evidence base on safety and efficacy of many drugs, and also given the outcomes I spoke of earlier. All right. So we've spoken about medicalisation, a little bit about commodification. I want to move on now to another mechanism that has enabled the mental health sector to thrive despite poor outcomes. And we will call this productivization. The process and in Vita, this idea is discussed quite broadly. The process by which our mental health sector has conceptualized suffering as disadvantageous to the economic order. So what does this mean? Before we get to that, I just want to show you this picture, really just to cheer you all up. You know, it's a lovely picture of Margaret Thatcher. No, it's more than that. It's not just because I want to cheer you up. Margaret Thatcher becomes Prime Minister, UK Prime Minister in 1979. A year later, Reagan takes over. And one of the key things that they had to solve when they came to power, by the way, they ushered in the neoliberal era, as you all know, of course. One of the key problems they had to solve was the problem of labor productivity, the output per hour of your labor. When they came into power, it was remarkably low, and they had to increase it, and they introduced a suite of social policies to try and achieve that, right? And they work. This graph could also be the human cost incurred as a consequence of those policies. The policies work. They have a number of knock-on effects for people's lives, but they work. So they're creating social policy to improve worker productivity. But at the same time, in 1980, DSM-3 is published, and at the same time, for the first time, psychiatry begins reclassifying underperformance at work as what it frames as occupational dysfunction. Yeah? And this becomes a key symptom of many forms of mental disorder, occupation dysfunction. And what is that? Well, just to quote, if you experience fractious working relationships, if you lack workplace motivation, or if you're simply working at a level deemed below expected, you will score high on the measure of occupational dysfunction, which was called the GAF, making you more liable to psychiatric diagnosis and treatment. So psychiatry's new project of medicalizing worker underperformance from the 1980s onwards aligns perfectly, of course, with this Reaganite and Thatcherite social policy, which is to increase labor productivity. So while neoliberal governments are aspiring to improve productivity with new social policies, psychiatrists and drug companies are promising to improve worker productivity by altering the very dynamics of your cells, your inner worlds, by tackling your low moods and your low motivation that is deemed to threaten the economic order. So the pathologization of any emotionally unproductive emotional state not only chimes with this new neoliberal zeitgeist, but it also sees drug companies marketing their pills as economic correctives. So there's a suite of reports being published by pharma companies sorry, you can't see the top there, but anyway, in the 80s and 90s. And effectively what they're arguing, a very simple argument, the same argument the World Health Organization used in the early 2000s to distribute antidepressants around the globe. And it's this: depression costs the economy a lot of money. Our drugs treat depression. Our drugs will save the economy a lot of money. This is the argument being made in a nutshell, and it's being made to government. And this economic argument to legitimate the distribution of new interventions becomes a key argument used again and again for new interventions over subsequent decades. So the mental health interventions that get implemented by government are those that profess to solve first and foremost economic problems. And in my book, I write about this program in the UK. I don't know if any of you have heard of this, perhaps not, the IAP program, the Increased Access to Psychological Therapy program. So it's a kind of national therapy program distributed throughout the NHS. And the argument upon which this was based was the same one. Depression costs the economy a lot of money. Absenteeism, presenteeism, disability payments, lost tax revenue. If we can solve depression with this service, we'll invest 500 million in this service. The return on that investment will be tenfold. And it's this argument put to Tony Blair in the mid-2000s that convinces Tony Blair to create this national therapy program. So it's all about economics. It's about using mental health provision to solve economic problems, not human problems, which again is why this service is utter rubbish. It fails. If you look at the outcomes, and by the way, these guys mark their own homework, but they measure their own success, which means they play a number of methodological games to inflate recovery rates, and lots of interesting work has been done doing the analyses properly, And if you do the analyses properly, what you find is that you're better off not going to IAPT when you're depressed than going to IAPT when you're depressed. Really quite startling. And so it doesn't work. And why? Well, the argument is, well, because it's not about you, it was about something else. And this is the problem. So the idea, I'll have to move on, I could say a lot more about IAP, but the idea that drugs and mental health interventions can serve productivity really becomes popular from the 1980s during the neoliberal era and begins to dramatically shape health policy in the UK. So we've looked at medicalisation, commodification, productivization as mechanisms that keep this failing system alive. Let's move to another one, individualism. And this is a great book, Economies of Abandonment by Elizabeth Pupnell. Neoliberalism fostering narratives of self-optimization. So what do I mean? So the individualism is the idea, effectively, that the person you are has little to do with the circumstances in which you were raised, and everything to do with what you have made of yourselves through individual drive, ambition, and effort. Every individual is a potential hero in their own story who can ascend the heights should they just be dedicated enough, should they just have the internal qualities necessary. So from this standpoint, you see the problem. Success is seen as an outcome of having these exceptional individual qualities rather than exceptional social privileges and advantages, while failure is seen as rooted in personal deficits rather than in lack of opportunity, discrimination, inequality, or social support. So this pivot in the 1980s towards locating failure in the self rather than in the system in which you're rooted not only helps justify cutting many welfare, labor, and social protections, but also nurtures subtly and slowly ever deeper political quietism in the populace when it comes to how we understand and manage failure and emotional distress. It's a product of something going wrong within you rather than within society. So from the 80s onwards, no longer is suffering seen as the organism's kind of protest against difficult social conditions that are holding you back, conditions that need to be rectified. And by the way, this idea was very much more prevalent in the 60s and 70s. It was very much at the hallmark of humanistic ways of thinking about distress, right? Distress as protest against bad things in the world that need to be fought and changed. But from the 1980s onwards, that ideology begins to disappear and is instead replaced with a new one, which sees distress as rather an index of an internal dysfunction that needs treatment. And this shift towards favoring self-reform through therapy and drug interventions over social reform through policy interventions was symbolized by many things, but one was, of course, in the US, where at that time in the 80s, the US Congress slashes funding for community mental health provision, while at the same time as it doubles funding for biological psychiatric treatments. We also witnessed the same in the UK, where the project of caring for patients in the community becomes tantamount to simply managing people's medications in the community. Okay, so individualism. Again, I could say a lot more about that. We have to move on. So we got medicalisation, commodification, productivization, individualism, and then the next one, depoliticization. The process by which our mental health sector has conceptualized suffering in ways that protect the current economy from criticism. And I just want to give you an example of depoliticization by drawing upon the work of China Mills, Professor China Mills, who's a professor of global mental health at the University of London. And this example concerns the terrible epidemic of farmer suicides that blighted central India between 2000 and 2010. So what was going on at that point? Well, at that time, large multinational agricultural companies were trying to create new markets in India for their products. And they were doing this by replacing the traditional crops that farmers had always used with genetically modified plants that didn't produce any seeds. So what this meant was that the farmers couldn't save the seeds and plant them for next year's crop as they'd always done. Now they had to buy expensive new plants each year from these multinationals. And what was happening? It was pushing these farmers into crushing debt and poverty. And as a result, and as the research was indicating, thousands of farmers were killing themselves under the resulting stress, mostly by drinking toxic pesticides. But in the face of these terrible suicides, rather than challenge the multinationals, the state sent in teams of psychiatrists and psychologists to tackle what was now being framed as a mental illness epidemic. It also launched a campaign with the World Health Organization to make antidepressants more freely available to the farmers. A campaign, it also turned out, was funded by these very multinational companies. It was as if the primary solution to the suicide epidemic was psychiatric rather than political, said Mills. Nowhere was suicide seen as a desperate response to a situation made unbearable by the multinationals. So this misuse of the mental illness narrative, I think, illustrates the essence of how depoliticization works. It effectively turns social problems into internal dysfunctions, making the self the site of reform and thereby exonerating harmful social, corporate, or political arrangements. And so, by implication, helps nullify in people the forces that push for social change. Remember Marx? Helps nullify in people the forces that push for social change. But depoliticization, of course, isn't just a problem in India. It operates across neoliberal economies as well. And to illustrate this, I want to turn to another example, which considers the problem of worker dissatisfaction in the UK, which is ballooning. I'll say a little bit more about that in a moment. But to introduce you to this idea, I want to refer you to these interesting statements that appeared on the London Tube in 2015, right? Suddenly they just appeared. Anonymous, no one knows still to this day who put them there, but they were everywhere. So you get on the train, you're on the way to work in the morning, and here we go. It's as if someone were out there making up pointless jobs just for the sake of keeping us working. Huge swathes of people spend their days performing tasks they secretly believe do not really need to be performed. How can one even begin to speak of dignity in work when one secretly feels one's job should not exist? Now, rather than kind of smiling Riley, another odd thing on the London Tube, actually, that's not what happens. These things set off a social media storm and they start to be discussed and the press picks up on them, etc., and so forth. And which is why I heard about them. And I became interested in them because at that time I was working on a research project at the University of Exeter, which was focusing on work-life balance and mental health. And one of the very dull things that we were doing was kind of a lit review on the stats related to worker dissatisfaction. Anyway, to cut a long story short, let me just review some of the stats. By the way, they've worsened since then. It's about 2016, 17. Around 2/3 of UK employees identify as being dissatisfied with or emotionally disengaged from the work they do. Emotionally disengaged means they have no emotional investment in their work. They could take it or leave it. It leaves them cold. 2/3. Around 40% feel their jobs make no meaningful contribution to society at all. These stats have been trending in the wrong direction, right, since the 1980s. Worker dissatisfaction has been getting worse and worse. Interestingly, during the pandemic, after the pandemic, there was a really interesting study published in Lancet, which looked at the effects of the lockdowns on emotional health. We've all heard the detrimental effects that lockdown had on mental health. We've all heard about that. But what this study actually showed was that a third of people experienced a boost in well-being as a consequence of lockdown, right? They loved it. They felt much better than usual. And when you ask those people why, what do they say? I didn't have to go to work. I hate work. It's a nightmare. Thankfully, for what So there's a lot of dissatisfaction out there in the community, and it's been trending in the wrong direction since the 80s for a host of reasons I will talk about in a moment. But of course, this is creating a huge economic problem, and many people have estimated the problem to be between 40 and 80 billion dollars a year lost to the UK economy through people quiet quitting. Have you heard that phrase? We've all done it. Switching off, going on Facebook, whatever it is, just not engaged. This is a massive problem, and it's bringing back the problem that Thatcher and Reagan tried to solve when they inaugurated neoliberalism, which was the labor productivity problem. It's back. Okay. So these guys have been brought in to help the mental health consultancies. Have any of you heard of mental health consultancies? Do you have them in where you're all from? I don't know if you do. They are everywhere in the UK, right? A mental health consultancy is an organization that goes into a workplace to solve the problem of low mood. Okay, we've got, at the last count, we had 80 in the UK. I think it's gone up to about 100 or so today. Now, what do these guys do? Well, let me tell you very briefly. They effectively train members of staff to be the go-to people in the office if someone is suffering emotionally, right? And then that trained individual will recommend to that suffering individual a number of things they should do to feel better again. So I wanted to learn a little bit about these programs, so I went and trained as a mental health first aider. I became one of these guys. I'm now the go-to person in my academic department for when there's distress around. It's a busy job. If you were here yesterday in the panel, right? No, I mean, I don't do anything at all. I mean, but anyway, this is what I was trained to do, and the training was interesting because it taught me what others were being taught. Firstly, I learned for the first time in 20 years, it baffled me what mental illness was. They told me on day one, which was remarkable. They also told me how to spot the signs of mental illness in my colleagues, right? So if I notice in one of you guys the symptoms, I approach you, excuse me, I've noticed you, and I recommend you go and seek provision. Now, ACAS, one of the biggest consultancies, writes a list. This is the list everyone follows to help them determine whether or not someone in the workforce is suffering from these problems. These are the things you need to look out for. Here's the list. Quote, this is a quote, common symptoms of mental illness might include increased in unexplained absences or sick leave, poor performance or timekeeping, poor decision making, lack of energy, uncommunicative or moody behavior. Come on now, this is most of us, is it not? But look, ACAS provides no reason, no rationale for why these experiences should be read as symptoms of mental illness. And this is all the more surprising since none of these experiences actually map onto any official diagnostic criteria, as problematic as those may be. But even more surprising is that all of these experiences could be better interpreted in non-medical ways, as classic signs of worker dissatisfaction and disengagement. In other words, this isn't mental illness. This is what people experience when they don't like their job. So what we have here with these companies is a simplistic reframing of dissatisfaction as a mental health issue for which the individual is largely responsible. But what is even more concerning is when Public Health England tried to study the effects of these consultancies, what they found, there was no evidence at all that they directly improve worker productivity, raise staff well-being. They don't actually save the economy any money. And yet, again, they're proliferating across the economy, their influence. So why? And this is why I believe they are, despite not getting the outcomes they promise. These consultancies effectively carefully control the narrative about what causes workplace distress and dissatisfaction in a way that is highly attractive to many employers. They locate workplace distress within individual ailments rather than institutional processes, thereby acquitting the workplace itself from any causal responsibility, while at the same time as providing employers with moral cover that they can now claim in good faith they are tackling poor mental health at work. They're taking it seriously. These consultancies are also heavily subsidized by the UK government. Why? When they're not necessarily generating good outcomes. Again, I believe because they are selling the idea that suffering at work is more to do with a growing epidemic of mental illness, just like we saw happening in the farmsteads of India, than with any wider structural problems in the economy. And by the way, here's a list of structural problems that sociologists have found to affect worker dissatisfaction. Things like this. This affects your productivity. Rising wage inequality, increased short-termism in the employment market, precarity, erosion of unionized working protections, longer working hours, growing pressure for dual working households, lower job security, higher job precarity, rapid expansion of the service sector. But such depoliticization of distress to protect the economic conditions of modern working life doesn't only permeate our workplaces, it colors every other social institution where mental health tropes are now embedded. And I don't have time to go into lots of other areas, but one of the issues we face in the UK, I'm not sure how this is where you all work, is growing levels of distress in the undergraduate population. And I've seen it over the last 20 years. I was talking to Byron yesterday about this. 20 years ago, young people left. I teach third years. There's a lot of optimism 20 years ago about leaving university and entering the big wide world. You could see it in them. You pick it up. Fast forward 20 years, there's not optimism. There's fear. They're afraid. They're scared of the world. And why? Well, I think they've got good reason to be scared of the world. I'd be terrified if I were them, right? They've got massive student debts we didn't have. They've got to repay. Their prospect of owning a home, that's gone, pretty much. The economy is in a terrible state. There's rising worker dissatisfaction, the things we're talking about. They're frightened of their future, and this is having a tangible effect on their subjective lives, their emotional states. And yet, in our university, we have these systems that say to students, let's have a mental health away day, right? We'll all go on our bikes and we'll go cycling into the park, or we'll go on a meditation retreat. This is how the universities are trying to solve these problems. These quick fix, superficial interventions that have nothing to do with the structural determinants of their distress, which aren't being focused on or managed. Okay. So in other words, I could say a lot more about that. And these are the rates of reported distress in undergraduate. You see how rapidly they've gone up. So what should be a national conversation about where neoliberal policy has corrosive emotional effects in our public sector, in our schools, in our workplaces, in our universities, in our wider economy, instead becomes a conversation about the growing epidemic of mental illness in all these domains of life. A conversation often draped in sanctimonious and conspicuously pious calls for more mental health provision, less mental health stigma, more mental health conversations. That is, in ever louder calls for more of the failing same. There's another mechanism, I can't talk about it now because I don't have time, is decollectivization. I think this is a really, really worrying mechanism which mental health services enact, but which cause a lot of problems. But I have to move on from that because I've only got a couple of minutes. So let me conclude because I've only got 2 minutes left. So to conclude, the alignment of the mental health sector with neoliberalism was not purposefully plotted behind the scenes. The actual truth, in my view, and in the view of many sociologists, and indeed someone like Marx, if we used his analysis, is far less enticing. Our mental health sector has, like most other major social institutions, simply come to embrace those ideas and practices that have best secured its own perpetuation. It has become what it is and has continued to thrive and expand despite presiding over very poor outcomes, simply by following the path of least resistance, by moving with rather than defying the dominant neoliberal tide. As Michel Foucault once put it, political power embraces the ideas and practices that best serve its own ideological aims and interests, ideas and practices that come to shape reality on the ground. So the interventions and ideas that get funded and implemented are ones that ignite the ideological passions of the powerful. The great fault in our services then lies just as much with those who have funded bad ideas as those who initially contrived them and then marketed them in politically enticing ways. Go back to our panel yesterday when we were talking about these very dynamics. So in other words, just as religion served industrial capitalism in the mid-1800s, the mental health sector in the UK today now performs a similar function in late capitalism. The mental health interventions that have been preferred since the 1980s are ones that have medicalized, pathologized, depoliticized, commodified, decollectivized, and individualized our emotional distress, robbing our suffering of its capacity to illuminate social ills, galvanize social action, and facilitate lasting and meaningful personal and social change. From this standpoint, I believe it's now correct to view the mental health sector in the UK as the new opium of the people, a sector that sedates us both literally and ideologically, a sector whose structural roots need to be more fully apprehended if we are to give meaningful reform a meaningful chance. So thanks for listening.